Medicity. I request Dr. Jabbar to please take over the session. Thank you, sir.
Thank you, madam, for the introduction. I think it is my pleasure to chair the session of Dr. Jabbar. And to introduce Dr. Jabbar is very easy because it's just a repetition of what all the posts I have heard in the past, like the CEO of Indian Institute of Diabetes and Professor of Endocrinology and Head of Endocrinology at Trivandrum. I was Professor and Head of Medicine in Trivandrum. Then first Professor of Endocrinology in government sector, but I was the first Professor of Endocrinology in Kerala to start DM course, so it may be in private sector at that time. Then the rest is and also I was also past inspector of Indian Medical Council DME, and Jabbar is now doing the job, excellent job, and contributing a lot of articles and all. And the topic, and I think Kottayam Medical College Medicine Department has given him the best topic possible because it is on vitamin D. This topic is very important because it is a very controversial topic, starting from the disease itself. So if you say the disease, vitamin deficiency disease, everybody agrees. But what is the entity of so-called insufficiency disease is a question mark which we have to debate, and we have to convince the audience about this. Then if you come to the requirements of this vitamin D, there is a lot of variation. ICMR have one recommendation, WHO has another recommendation, American Diabetic Association, American Endocrine Association has another definition. Then pharma companies may bring some other definition, the minimum levels, and laboratories also come like that. So that is going to be a controversial area. Third thing is about it is now told to be the panacea for everything. For any disease coming in medical college, medicine, okay, anything, it is better to look at the vitamin D because that may be contributing some way to it. And whether you believe it or not, it is the pharma companies have made a lot of good fortune from this entity which has been there for the last decade. I think 1 year, for the last 10 years, it has been going on like this with all this data. And I am sure Dr. Jabbar is going to highlight it as the daily requirements, the action, and the differential diagnosis, and also how much it is contributing to the so-called vitamin D insufficiency disorders, how much it is clinically relevant, and what's the practice physician must know. So, Dr. Jabbar, please take over and entertain us about this topic. Dr. Jabbar, please.
So, is it a hormone or vitamin? If you remember the structure of the vitamin D, that has got a steroid structure, okay? And by definitions, vitamins are not produced in your body. Whereas, you know that vitamin D is produced in plenty in your body. That is one of the important property of vitamin D. Yet another property of the vitamin D that is carried or the action is happening in some other place. So considering all these factors, people are thinking that vitamin D is not a true vitamin, probably is a hormone. Around exposure to sunlight, that will produce most of the hormones or vitamin D in the body. It's around 80%. Most active form of vitamin D, D3 is 125 D3. But it's very, very powerful, and in clinical practice, we are not really looking into that. And the majority of the dietary vitamin D is coming from an animal source, a very small contribution from plant source. If you see the basic structure or synthesis of vitamin D, you have sunlight here. That will produce your pre-vitamin D3 and subsequently cholecalciferol that is happening in the Malpighi layer of the dermis. With see all these vitamin D3 that will shifting into the hepatic tissue with the help of binding globulins. In the hepatic tissue, 25 hydroxylation is happening, and subsequently that will convert into the 125 dihydroxycholecalciferol with the help of 1-hydroxylase. The importance is this enzyme is very important. This is influenced by lot of factors negatively with the calcium, 25 hydroxy D3, FGF23, and positively the PTH will stimulate and hypophosphatemia is also stimulating. So a crucial question, probably one of the tricky question in this area is, you are exposed to sun for a long time. So in North India, you are working in the paddy field. Will you develop toxicity? What is your impression, Dr. Krishna Kumar? Will you develop vitamin D toxicity if you are working for a long time, 24 hours? Now I can hear the question answer anyway. That will not, because what will happen is, with the continued exposure to sun, lot of inactive metabolites, tachysterol or lumisterol is produced. All these inactive molecules are not biologically active, so you won't get any toxicity at all, even if you are working for 24 hours in the sunlight. Now, eventually what will happen is, all these cholecalciferol that is binding to vitamin D binding proteins, that is going to the liver, and subsequently these things are happening. So what is the important statement here? In clinical practice, you are looking for 25 hydroxy D3, it's not 125. Even if you are asking for 125 hydroxy, you are measuring vitamin D as well as binding protein. You should remember all those things. Suppose you have a condition where vitamin D binding protein is reduced, you will get reduction of vitamin D or 25 hydroxy. Always look into the clinical profile, then only you interpret the data. That's a very important statement. Again, a controversial issue comes, as Jabbar sir was discussing, lot of controversies in this area. The normal plasma level as per the data ranges from 2 to 30 nanograms. Why it was taken as 30 nanograms? Because when the level comes down less than 30 nanograms, your PTH start increasing. When the level comes down to less than 20, the absorption of calcium from the gastrointestinal tract is also coming down. So considering all these physiological aspects, the definition probably less than 30 is a little deficient, and less than 20 is clinically significant. You are not looking for 125, but just for the completion's sake, I'm putting the normative data for also here. Half-life of 25 hydroxy is 2 to 3 weeks. Again, what is the clinical significance of all those things? When I was a student, probably Dr. R.V. Jabbar sir was also using arachidol for the treatment of hypoparathyroidism. So if you are giving arachidol, long-acting preparations, if the patient develops hypercalcemia or toxicity due to your drug, what will happen? You have to stop and you should wait for a long time. Exactly, that is the reason people are using active form of vitamin D3, that is 125 hydroxy D3. The half-life is max 6 hours, not more than that. So very easy to manipulate, or management is very easy in our clinical practice. Yet another important statement, you should read the top panel. 125 hydroxy is also produced in keratinocytes and trophoblastic tissues and granuloma. What is the importance of this statement? The importance comes if the patient has got some sort of granuloma like sarcoidosis, all those things, you will get elevation of 125 D3. That's a message. Now, I want to introduce another statement here. Minimal erythema dose. What is the importance? If you go to sunlight, you will develop little erythema. That's only because of heat. If the erythema is lasting more than 24 hours, yes, you will develop little vitamin D with that sun exposure. What should be the minimal erythema dose? Around 6 to 10% of your body, which includes your face and hand, at least for 1 hour. That will produce around 1,000 international units of vitamin D3. Especially the time given is between 10 a.m. to 3 p.m. So something known as zenith angle. I don't want to discuss it in detail because the time factor. So the exposure is also differing depending upon the skin type. So there are 6 types of skin types have been described. We are having Indians, we are having 6th type. So the average exposure should be around 60 to 90 minutes. That's a message. Now, requirement, again, lot of controversy. ICMR recommendation is there. There is something like American Association of Clinical Endocrine recommendation, National Osteoporosis Foundation recommendation is there. In the Institute of Medicine is recommendation is there. So by and large, recommendations around 600 international units. Once the age increases or exceeds more than 70 years, the 1-alpha hydroxylation is coming down, so the requirement goes up to 800 international units. That's all about the requirement. There are a lot of controversy, there are a lot of data which you can interpret in a different way. Now, this is what is happening. Multiple levels you have action. Everybody knows that the SAMON is one of the important target. Calcium absorption, one of the most important action of 125D3 is absorption of calcium. And cardiovascular system, I'll be discussing that. Muscle strength and PTH secretion, there are multiple levels your vitamin 125 hydroxy D3 is acting. Now, I want to give a very important message. I still remember my teacher, Dr. R.V. Jagamar sir, was asking, don't ask for 125 hydroxy for all patients because it's a very costly investigation, and you should know little bit about the assay methods. What is the best method? Best method probably LCMS. You can read here, but LCMS is not available freely in clinical practice. But there are other methods. In our most of the laboratories in Kottayam, they are using chemiluminescence assay. But what is written in the textbook is radioimmunoassay is almost par with your LCMS. Whatever be the method, you should know there are problems with the assay. Also, you should be aware of that. Otherwise, difficult to interpret the data. Now, this is vitamin D binding protein. I'm not discussing that, but this is a very important the molecule which you should know if you are interpreting the vitamin D level. Now, what are the conditions you will get increased levels? Increased levels is described in pregnancy, acromegaly, OCPs, multiple sclerosis, psychosis, aspirin treatment. On the right hand, you can see there are conditions where the vitamin D binding proteins are coming down. This is very important if you are asking for vitamin D level in certain situations. If you can read the exhaustive list, this list is highly exhaustive. What you should know, see in such a situation like in a protein syndrome, liver, end-stage liver disease, critical illness, smoking, menopausal, all these situations, you can get changes in the vitamin D binding proteins, and eventually your results will be falsely negative. Remember that. Now, one important statement, it's a very important truth. There is no doubt about that. What are the truths about the vitamin D? Very simple. Too much of anything, adhigamayal amridam visham. Exactly that is what is happening here. I will discuss one important case which I got from Kayangulam. One lady, she is taking vitamin D for the last so many months. In fact, it's not 1 month, so many months. And she came to a physician with a persistent headache, and subsequently on evaluation, clinical evaluation, they could pick up little changes, not very florid of papilledema, but there are signs of papilledema, and subsequently they could document hypercalcemia. It was a case of vitamin D intoxication. My friends, what I want to tell you that it's very common to see lot of vitamin D preparations, or your patients are taking lot of vitamin D preparation. Please look into the calcium, at least these are the words of my teacher, Dr. R.V. Jagamar. So always look for the calcium. Don't ask for vitamin D every visit. This is not economical. The cost is around 1,000 rupees per test. So it was a case of vitamin D intoxication. So we treated with the standard treatment for vitamin D intoxication, and patient recovered from the issue. Now, second important truth is vitamin D deficiency leads to metabolic bone disease in the form of rickets and osteomalacia. You can see all the manifestations, changes in the wrist joint. You can see the changes in the knee joint. So this is one of the important cause. So vitamin D deficiency, definitely that can produce metabolic bone disease. Now, don't think that all cases of rickets is due to your vitamin D deficiency. Please remember, if you get a case like this is not shape 1. This is because of the alopecia, changing the resistant type of rickets. And what I want to tell you, one carry-home message here is, these are the changes of rickets. You can see here the irregularity, you can see widening also, you can see here, you can see the bowing of the leg. But if the patient is taking sufficient amount of vitamin D or optimum level of vitamin D, and patients are not showing the evidence of healing, think about the possibility of vitamin D resistant rickets. Very important. This is yet another condition. You can see lot of deformities. This much of deformity, think little away from vitamin D deficiency. Think about the possibility of hyperphosphatemia, which is also an important cause for metabolic bone disease or rickets osteomalacia. Can you spot the diagnosis, my friends, here? So you can see your patient has got classical wine-swept deformity. Here you have varus deformity. Here you have valgus deformity. On the X-ray, you can see the changes of metabolic bone disease, rickets osteomalacia. In addition to that, you have calcification somewhere in the paravertebral region. Any diagnosis, Krishna Kumar? Bipin? This is it's not a case of vitamin D deficiency rickets. It's a case of renal tubular acidosis. You can see the changes here. Nephrocalcinosis, you can see. Metabolic bone disease changes, you can see, and deformities also. So even the vitamin deficiency can produce metabolic bone disease in the form of rickets osteomalacia. Think about resistant situations also and treatable conditions also. So what is the cutoff? Again, controversies are coming up. Probably less than 20, you are dealing with the vitamin D deficiency or insufficiency. And more than 30, I think there is not much controversy. You are in the phase of vitamin D sufficiency state, and level more than 150 nanograms per ml is suggestive of vitamin D intoxication. Now, what is the prevalence? Prevalence, I can't quote all the studies here. There are various studies, Hadinaran studies, Marwa study, see the Goswami study. All the studies showed the prevalence of vitamin D deficiency is very high. You can quote, see the figure here, around 84 to 100 in all groups of patients, maybe pregnant, maybe neonatal, maybe adults, children, everywhere vitamin D deficiency is very rampant. Yet another issue is immune diseases. Autoimmune disease is closely linked with vitamin D deficiency. This is the study from Lova Women's Health Study, which showed there is inverse relation with the severity because of multiple factors involved in the autoimmunity or immune dysregulation. All these are the mechanisms. Decreased in vitro production of inflammatory cytokines, increased production of anti-inflammatory cytokines, inhibit monocyte production of inflammatory cytokines. So if you give sufficient amount of vitamin D, probably you can reduce the severity of the disease. This is the level of vitamin D in Crohn's disease, again inversely proportional. These are the data from European gastroenterology journals. Vitamin D and sepsis, even for me, is a very new subject. See, patients with the vitamin D deficiency had higher risk for sepsis compared to patients without deficiency. Very important statement. This came in Anesthesiology Journal, British Medical Journal. This is the paper. Vitamin D binding protein, not vitamin D alone, is associated with the septic shock mortality. So what I want to tell you that always you should have a sufficient or optimum quantity of vitamin D for your good immunological response. That is the message. There is something like a pulmonary disease or asthma. Again, there is an inverse relation. What is noted in this journal, like see, most of the journal says in a vitamin deficiency, vitamin D supplementation reduces the risk of asthma, especially in patients with the vitamin D insufficiency. So it seems those who are having resistant type of asthma or COPD, maybe vitamin D may be useful. Of course, a controversial paper which needs more studies and discussion. This is another seasonal infection. All sorts of respiratory infection, maybe influenza, maybe acute respiratory infection. Wherever you go, see, you can see here the American Journal of Clinical Nutrition says that if the patient has got low levels of vitamin D, See, you can see the prevalence here, 18 out of 167, whereas 31 out of 167. So what I want to tell you that vitamin D supplementation may be useful. Another one of the contributing factor here is influenza is occurring in the winter time. So that time vitamin D levels comes down further, so patient get severe infection. This is regarding the cancer. Cancer, these are the articles from JCM. You can see here there is definitely inverse relation between vitamin D and colorectal and other cancers, which is well documented in the literature, especially Journal of Clinical Endocrine Metabolism. And vitamin D and depression, there is a link between depression and vitamin D. What is shown here, this is one of the Journal of Psychological Medicine. Multiple mechanisms are operating, and eventually these patients are more prone for depression, more prone for resistant type of depression. That is a message from these two papers. Now, preeclampsia, I'm not discussing in detail, but there is a link between preeclampsia and vitamin D. So sufficient amount or supplementation of vitamins D may be useful for preventing eclampsia. This is the paper, again, the clinical nutrition paper, which endorses the view of this author. Vitamin D and psoriasis is a well-documented fact. And those who are having vitamin D, the severity of the psoriasis, resistance type of psoriasis is not that uncommon. So the requirement should be given properly to reduce the severity of psoriasis. Now coming to endocrinology, again, vitamin D type 1. But how to prevent type 1? Extremely difficult. But there are papers saying that you can manipulate, or nutraceutical manipulation is possible. One of the method is vitamin D supplementation. Intake of vitamin D and risk of diabetes definitely is useful, and some papers saying that is very useful for preventing type 1. Type 1, please remember type 1, not type 2. Vitamin D supplementation early childhood and risk of type 1 is also coming down if you are giving sufficient amount of vitamin D, not the mega dose of vitamin D. This is ultraviolet irradiance. So what is happening, you will have the level of UVB is coming down. So eventually vitamin D will come down. So what I want to tell you that vitamin D should be maintained to a normal level if you are staying in place where the sunlight exposure is minimal. Now certain myths also there. Vascular system influence, cardiovascular disease influence, musculoskeletal, very common to hear, and so falls are reduced, especially in geriatric population. If you want to reduce the number of falls, you can give the vitamin D. And type 2 diabetes mellitus also, there are papers, of course the negative papers for us, and little bit or one slide about COVID-19. Vitamin D, there is no strong linkage between type 2 and the vitamin D supplementation. Please take a message. There is no strong link. There is no authenticity of all these papers. And this is another study, DEPT study, which also showed there is no strong linkage between vitamin D and your diabetes mellitus. Cardiovascular and diabetes disease, what you can see, this is published in NEGM only recently, probably less than 2 years, where also no effect is documented with the vitamin D. Very important. This is Sang et al. Also endorsing the view of the previous author, what they show that the vital study did not show any improvement in terms of cardiovascular benefit. That is a message. This important paper is from JCM, which showed postprandial arterial stiffness and inflammation in vitamin D. Doesn't look like useful with your vitamin D, so it's a negative study. So there are a lot of controversial papers. Even the vitamin D and musculoskeletal, not definitely engaged. Even though people are discussing like that, the link is not strongly proved in any of the studies available with us. This is another annual high dose oral vitamin D. So probably it's a negative issue here that will increase the risk of falls and fractures. This is yet another paper looking into the bond structure. If you are giving vitamin D, see unnecessarily, definitely there is no linkage. but there are some papers saying that, see, if you are supplementing or replacing the vitamin D properly, you can reduce the number of falls. This is regarding vitamin D and COVID. What is shown here, see, you need to look into that data again. What is written here, you can see the data is not very strong. That strong data is still lacking, and this should be investigated further. Now, why the studies are contradictory, we do not know. There is something like, see, problems with the vitamin D assessment, and concept of reverse causality is also coming up. What is written here, high levels dangerous, optimal level is okay, and low level is not acceptable. So too little or too much of vitamin D is definitely harmful. That is the only take-home message from me for today. Relation between vitamin D and mortality is a U-shaped, or you can call it as inverse shaped curve. Too little vitamin D is definitely harmful, especially in terms of metabolic bone disease, and the high dose is also not good. And the high incidence of vitamin D levels decreases disease-related inflammatory state is predominantly based on reversed causality. And please don't ask for 20-hydroxy without any reason. Look into the clinical data, then ask for the investigation properly. Ladies and gentlemen, for the timing, I'm signing off. Thank you very much for the kind attention.
Thank you. Thank you, Dr. Jabbar, for that excellent presentation covering all the aspects of vitamin D and showing and bringing out the truth in it. That is, there is some evidence and some evidence against it also is there, and highlighting the fact. Now, now it is open for comments and questions. I can't see in I've got the iPad, so I can't see any questions here. Who are Dr.
Sir, if it's okay, shall I read out the questions one by one?
Yeah.
Yes, sure, please.
So the first question is, is vitamin D deficiency myopathy common in our population?
See, our population studies are not aware of that. Vitamin D deficiency can produce few issues. One, see, the actin and myosin, these are the proteins responsible for the strength and contraction of the muscles. That will come down. Number two, see, the transformation of myogenic stem cell to myoblast is also coming down. And eventually this will go for atrophy of type 2 fiber. That is the cause of muscle atrophy. In addition to that, if the patient has got vitamin D deficiency, that can produce little reduction of calcium. In order to maintain the calcium, your PTH action will come up. You can call it a secondary hyperparathyroidism. This can produce little hypophosphatemia, that also contributing for muscle disease. So because of multiple mechanisms, it's possible. That is what is written in the literature. In India, any study with that, I'm not aware of that. You can ask the question to Jaykumar sir.
No, I don't know.
Jaykumar sir, would you like to comment on that?
Yes, what he said is theoretical knowledge. No studies here, but one more thing is that is, when you give statins for correcting cholesterol, lipids lavishly, and some other patients are complaining of myopathy and weakness and pain and all. And there are some studies which showed that if you top up these people first with vitamin D, make it the therapeutic level, and then give statins, some of these patients may be able to tolerate this. I don't know whether it is being accepted by cardiologists, but there are some studies which showed that patients who are presenting with myopathy due to statin therapy, they are usually benefited. Some of them will be benefited by correcting the vitamin D level to within the normal levels. Otherwise, I am not.
Ramesh sir is asking a question. What is the ideal time for sun exposure in Kerala and how long? I think we have answered that question. Yes. Sir, something known as, yes sir, something known as zenith angle, okay, where you have maximum amount of ultraviolet B radiation. So the ideal time in Kerala, somewhere around 10 AM to 3 PM. And the second question, the duration of exposure. But for me, It's around 60 to 90 minutes. Suppose you have a very fair skin, saipe-like skin, where probably 20 minutes, 10 to 20 minutes acceptable. Next
I
question
think,
is how
yes,
aggressive should be? Yes, sir.
one point about the sun exposure.
Ah.
I think this is, see, who has got the time between 10 and 3 p.m., 10 a.m. to 3 p.m. to go and stand there for 30 minutes. Second thing is be practical. See,
Yeah.
our ladies, especially the 50% of the population is made up of ladies. And
Yeah.
who will like to get the tan? Because color is very important. The facial color, the appearance and color of the skin is very important in the life of the people. So even the ladies, when they go to the sun, they take the umbrella and use it. They don't want to get
Yes,
dark and tan by this. So I think taken together, there is no meaning in asking the patient to go to sunlight and wait in the sunlight to get the vitamin D requirement. Let them take one tablets of 60,000 units in a month. In a month,
Yeah.
that will provide the requirement. And only 20 rupees in a month.
Another issue, if you are exposing your palms and hands, sorry, we are all putting half shirts, right? And ladies, they are exposing little neck, little back and all. And both palm and foot is open. So I think that will produce around 1,600 to 1,000 international units. So if you are exposing this much area, is good. Or if you can expose more, definitely that will be an ideal one. Next question, Cyril Jacob Kurian. How aggressive should we be monitoring with vitamin D levels in clinically asymptomatic? Exactly, that's the reason. I think Sir Jabbar sir is the correct person to answer the question. So you can't go for vitamin D assay all the time because two things. One, we do not know the sensitivity of the assay. Number two is the costly measure. Number three, you look into the calcium, at least one calcium. So I think the aggressive vitamin D assay is not acceptable. I don't accept that. Definitely you can ask for calcium, 1,000 rupees. But if the patient is having a situation like that, definitely you can. Otherwise, there is no point. Sir, please add to the question.
Okay, the only thing is I fully agree. See, the question is if you are only suspecting, if you are only planning to give a physiological replacement like 1,000 units of vitamin D per day, that is around 60,000 units in 1 to 2 months, no need to measure the level. But if you are suspecting that the clinical condition is attributable to a vitamin D deficiency, then you will have to document it that you have found out the cause for the present illness. Somebody having real problems and where all the other investigations are negative, then you can tie up. Otherwise, there is no. And as Dr. Jabbar has clearly shown that majority of the Indian studies have confirmed that the percentage of vitamin D deficiency is so common in the population. 40 to 90% of the population is vitamin D deficiency. So there is no meaning in measuring this costly investigation unless it is absolutely indicated. So I fully support Dr. Jabbar's view that is only essential if you are suspecting a clinical condition where this is contributing. Otherwise, it is for just giving the replacement for the Tom, Dick and Harry of the Indian population. Then there's no need to measure.
So another pertinent question, daily vitamin D supplementation versus weekly versus monthly. So see what we are doing is monthly, it's okay. Okay, monthly one tablets. Ideally speaking, now see if you want to replace properly, you should go for weekly for 8 weeks. Then you go for monthly. But we are following, since there is no documentation, we are going for one tablet of 60,000 monthly. That's okay for replacement.
I think Dr. Jabbar, there was a study in KEM hospital, one of the DLPs.
Yes, sir. Yes, sir.
Giving vitamin D different forms, injectable form, oral form, daily form, weekly form, and monthly form. And that thesis study has confirmed that there is not much significant difference between these things.
Yes,
at the end of the day, giving, as he said, weekly, the top up the deficiency with the weekly dose and maintain with the monthly dose is enough. That is the conclusion of that thesis. I don't know whether it has been published because I was an examiner there, so I happen to be aware of that study.
Sir, Suvan is giving a message. Okay, sorry, time's up.
Okay, thank you very much.
Thank you very much.
Thank you. I think Dr. Jabbar has given an excellent talk and there was a lot of questions and we have overshot the time. Sorry, Dr. Suvan, for us for overshooting the time, but there are the because the first batsman may give a good score, and so we will have to accept that one. So thank you very much, and thanks the Kottayam Department of Medicine for giving me a chance to chair this session. Thank you.
Thanks to my family. Thank you very much.
Thank you, Dr. Jabbar. Thank you, Dr. Jayamar, sir. It is a pleasure to see you.